Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. In the name of Allah, most gracious, most merciful, I'm happy to start this webinar event under the umbrella of Saudi Society of Men's Health. Today, we are going to talk about the forgetting problem of overactive bladder, and it gives me the pleasure to introduce our moderator, Dr. Ghadir Al-Sheikh, who is a consultant obstetric gynecologist and urogynecologist and pelvic reconstructive surgeon from the Department of Obstetric and Gynecology, College of Medicine at King Saud University. She is a professor of obstetric. She has obtained her medical degree from University of Ottawa, and she has a lot of leadership positions, including the Dean of Faculty of Medicine at Princess Noura bint Abdul Rahman, and the head of urogynecology section at King Khalid University Hospital. She has published a lot of publications, more than 40 publications in international peer-reviewed journals. She has also participated and organized a lot of local and international events. So it's my pleasure to introduce Professor Ghadir Al-Sheikh.
Thank you, Prof. Saleh. It is with great pleasure to introduce our wonderful speaker for today, Professor Waleed Al-Taweel. He's a professor in urology in King Faisal Specialist Hospital and Research Center. He has a subspecialty in voiding dysfunction and female urology. He did his residency and fellowship training in McGill, Canada. He has numerous publications in the field, more than about 57 publications in international journals, and he has a plethora of educational activities. So it's with great pleasure, and we all look forward to this fruitful talk that he's going to give us today about the overactive bladder, the forgotten issue. So I will give the talk to Professor Waleed.
Well, thank you very much, Professor Ghadir, and it's always a pleasure to be with you and with someone like Professor Ghadir Al-Sheikh, who's expert also in voiding dysfunction. And I would like to start thanking Professor Saleh, actually, for his tremendous work in men's, Saudi Men's Society, where I think he did a lot of work related to incontinence, plus the other subspecialty related to the men's health. And I'd like to thank also Saja, because they always keep themselves with doctors in terms of education, with a lot of support. And this webinar is an example of Saja support. Before I start my presentation, I would like Samer actually to give us an introductory questions. I would say that, like just only to stimulate our audience, whom I have a great respect to them to attend this webinar at 9:30 in the weekend. And this is, what you pay for being a doctor. So we'll start with the questions, and later on in the presentation, I would tell you the answer or the correct answer for each question. Go ahead, please. Okay, so now I think I can start my presentation. And first, I would like to welcome again our audience. I hope everybody is hearing me well. And the definition, again, based on the standard of terminology provided by International Continence Society, that overactive bladder was defined as the presence of urinary urgency, usually combined by frequency nocturia with or without urgent continence, in the absence of UTI or other obvious pathology. Now, we said in the next slide, we are going to talk about urgency to define it, because it's important. Many people, they think that the urge, which is usually we have every day, you know, which is a normal sensation, is urgency. This is not, because urgency, it means that you have a sudden and compelling desire to pass urine, which is, you cannot defer. So that's the difference between urgency and the urge. The urge, you know, I could have the urge now, but probably I can wait another 10-15 minutes until I go to the bathroom. While in the urgency, you don't have the chance to wait until you go to the bathroom. Now, people always, you know, like would like to have, you know, an understandable pathology that would be the cause of any disease, because once you understand it, you would be able to cure. And as you know, overactive bladder is not a curable disease. We have a treatment, but we don't have a curable treatment that will take a medication like antibiotic, for example, and after 10 or 1 week, you're gonna have no more infection. But we know that there is a lot of theories behind overactive bladder, which is either related to change in our changes in the urothelium, that it's very complex, the bladder urothelium, where there is a lot of receptors, a lot of agents, I would say, that, you know, like work together, you know, like to give us a relaxed bladder. And any changes in that environment would cause irritability to the bladder and cause overactive bladder. The other theory that it could be neurogenic, related to the changes in the nervous structure within the bladder wall or the nerve supplying the bladder. Or could be the changes within the muscle itself of the bladder, the detrusor muscle, where there is a lot of, I would say, excitability that lead to overactive bladder. So there's a lot of theory. We don't know what is the exact cause, but we know that there is a lot of theory or pathophysiologies that would lead to overactive bladder. Now, when I think majority answered the question in a correct way. So overactive bladder is, the first question, is only problem for elderly women? No, it affects male, female, pediatric. There is no special effect to any sex or age. It's affect any age, any sex, okay? And there is a lot of prevalence study was done in the Western society, and EPIC study, actually, this is one of the biggest study that was published with thousands of female and male with different age groups, and involving Canada, Italy, Germany, Sweden, UK, and you can see that this disease affects men and women, but it's increase with increase in age. So elderly, they have more chance to have overactive bladder compared to the young population. Now, many times people, they don't study the local people, actually, and we did. Actually, there's more than one study. This is a study that I did myself in Riyadh, looking at the prevalence of a risk factor for urinary incontinence in Saudi women. And in that study, we have almost 4,500 candidates. And we found that there is 29% of women in Riyadh suffered from urinary incontinence, and diabetes was the most significant factors. About 28% of the patient, they would have overactive bladder symptoms. And you can see that, you know, like, again, elderly, they have a higher chance to have overactive bladder. similar study actually was published by other groups, and I think Dr. Ghadir was part of the other study, and it gives more or less similar results. Now, I always tell the patient that yes, overactive bladder is not like hypertension or diabetes where you need to treat your patients, otherwise they would end up with a major complication. Incontinence psychologically could be worse on the patients, where they might have a very bad quality of life, even though if you did not treat it, this would not end up with a patient losing their life because she or he is incontinent. But they will have a terrible, probably lifestyle if you did not treat it. And in this study, for example, you know, like they're comparing the outcome with overactive bladders in people, you know, like with a serious chronic condition and the absence from work. And they found that overactive bladder impact in work is worse than many other chronic conditions, including rheumatoid arthritis and asthma. Now, economic cost of overactive bladder is another important factor that in the United States, people always look at the cost of almost every single disease that affect the general population, and overactive bladder found to be very costly to the government and to the country. And unfortunately, in our country, probably we don't have the cost data. And I think the government take the burden of payment for the patient with overactive bladder or urinary incontinence in terms of medical treatment and sometimes diapers and other accessories that the patient would need. If you look in the United States, that the expected cost in 2020 is 82 billion, which is a lot of money. It's beyond that people sometimes imagine. And it is found to be 5-fold higher than older and non-comprehensive estimate that was done previously in 2015 or before. And the costs are higher than previously published data in the United States, even in Europe, because this analysis relies more on current data and real-world age and sex-specific treatment pattern and cost. So it is costly, and we have to look at this disease as a serious disease in terms of cost into the Ministry of Health or government, or even in the insurance companies. Now, of course, what is important that we need to know is how we're going to diagnose patient with overactive bladder. As you know that, you know, there's many diseases that could cause the same symptoms of overactive bladder. Patient with UTI, patient with the neurogenic cause, patient with polydipsia, patient with, you know, like BBH, and name it. There is a lot of disease that they might give the same symptoms. So as a doctor and in any disease, you need to talk about the duration of the symptoms. You need to go specific to the bladder storage symptoms. If the patient has urgency, urgent incontinence, frequency, how many times you go to the bathroom. Patient goes maybe 5 times, they think it is a lot of times they go to the bathroom, while 5 times, 6 times, 7 times, this could be normal. And also nocturia. People should not wake up at night to urinate. And usually patients with overactive bladder, they have nocturia at least 1 to 2 times or more per night. And of course, you need to ask about stress incontinence, especially in the female, because sometimes it's mixed between urgent incontinence, stress incontinence, And usually, if you have someone with a genuine stress incontinence, they should not go to bathroom at night. I mean, there's no necturia unless they have overactive bladder symptoms. Bladder emptying, ask the patient about hesitancy, straining to void, and if they go into retention before, and what about their stream, and if it is intermittent. Because again, any urethral stricture, any enlarged prostate would cause the patient to go to the bathroom more frequently. And don't forget that there's many patients, and I have seen a lot of those in the clinic, that they drink a lot of fluid. So excessive fluid intake is another cause of frequency, urgency, and sometimes if you don't reach the bathroom in a good time, you might have urgency incontinence. And I still remember, one patient that he comes and complains that he has to go a lot to the bathroom. And then when you take the history, he drinks 3 cups of coffee in the morning, plus water, plus tea. So I think it's a problem if you don't go to the bathroom. You have to go to the bathroom more frequent than anybody else. And of course, don't forget that we are in Saudi Arabia, and the diabetes is one of the very common, I would say, in our society. Probably 25% of the population at adult age, maybe they have diabetes. And ask about, Parkinson's, spinal cord injury, previous radiation, previous surgery, prolapse in ladies, because all these can be a factor comes with or cause urinary incontinence or overactive bladder symptoms. Don't forget that exam is very important in male and female. Pelvic exam in female is very important when you have someone with overactive bladder symptoms or urinary incontinence. Same thing, you need to do digital rectal exam for male when they come with LUTS, because you want to make sure that they don't have prostate pathology. And you need to do abdominal exam, GU exam, pelvic floor exam, and in menopause, women, you want to make sure that there's no atrophic vaginitis, because sometimes even treating the atrophic vaginitis could be the treatment. And you should assess for other factors that could come with it, which is prolapse. And we do a neurological exam or a focused neurological exam for the perineal area and the pelvic floor muscle. And since some medication that we are using could cause a cognitive impairment, you need to assess that in elderly, because anticholinergic might cause cognitive impairment. I hope I'm not fast, Dr. Ghadir. Okay.
No, I think speed is perfect. And I just want to tell the audience that we have an option for question and answers. So if you can type your questions, because the chat icon is disabled, and at the end of the presentation, we'll be happy to answer all of the questions.
Great. Thank you, Dr. Ghadir. So the next question that you have answered is, you need to do urine analysis in all cases with overactive bladder? And the answer is yes. And the reason why, because as we said before, you need to rule out infection. You need to make sure that the patient does not have other pathology that cause overactive bladder symptoms, but it's not an overactive bladder. Urine analysis, I know all of you would do it in your office or in your clinic, and it's very easy, very simple to do. Either you can do it in your office or you send it to the lab. And urine culture is not usually necessary unless you have positive nitrate or leukocyte in the dipstick or in the microscope when it goes to the lab. Now, other tests we do in the clinic after you take the history, physical exam, And I would ask the patient also to do a voiding diary, and the voiding diary where basically patient would write how many times he or she would go to the bathroom per day, whenever they have incident, how much of a fluid intake they would consume every day. So these are the voiding diary is important actually when you want to check for your patient. And why? Because sometimes one drop would cause a lot of problem for one patient, while others might use pads every day when you take the history at least 2-3 times, but they think it's fine, especially in our society, when people, they do think that it is, especially in elderly women, that, you know, it's fine to leak sometimes urine, which is not true. People should never leak unless they have a pathology. So after you take the history and the urine analysis, you're going to do a very simple test, which is always available in the Office of Urology, which is doing a post-void residual with this bladder scanner. Very easy, very simple, because you want to make sure that this patient empty the bladder well, and it's not related to incomplete emptying, because sometimes the patient, they have sort of incomplete emptying that cause a lot of symptoms to them, especially men with BBH and high residual. And after that, you know, like doing urine analysis, doing the bladder scan, and doing the voiding diary, and patient, usually 1 or 2 days of voiding diary is good enough. We prefer 2 days. And if you give the patient more than 2 days, they don't complete it because it's, you know, it's a bit too much for them to write every single time they go to the bathroom and how much they drink, how much they urinate, and if they have incidents or incontinence. And based on this information, you can go and treat the patient if you are happy and the patient emptying well, the history was clear, physical exam, nothing else would assume other pathology. I would go ahead and treat, and we're gonna go into treatment after. However, urodynamic is always mentioned in overactive bladder because it is a very important test in urology. And urodynamic is not needed in every case at the first or initial presentation. So we don't need to do it. And I believe that some of you would see overactive bladder patient more than probably someone who is subspecialized like me, because I usually see the refractory cases or the difficult cases or the patient who did not improve. And at that time, I will do urodynamic for everybody because now it's indicated, patient did not improve. But in my practice, because even if I see initial presentation patient, I do urodynamic because I work in academic institute. I you know, have a routine for my patients, so I do it. But doctors in family medicine or in gynecology or in medicine, if you see those patients or geriatric, I would say, you know, like, of course, it's fine. If you do the initial test that I mentioned, urodynamic is not indicated, and you can go ahead and start the patient on treatment, and we will talk about treatment after. Now, this is the urodynamic. So urodynamic machine basically is a machine that has pressure transducer, and there's a computer with a software that will take the tubes that connected to the urethra and one tube to the rectum into this screen, and would give you the final scale at the end. And it's a bit complicated to read it. You need a lot of work actually to understand it. but it's not very difficult to do it. And we consider it a minimal invasive procedure. Now, at the end, this is the graph of the scale, you know, that you would have, and this is the finding that we call it detrusor overactivity that document that this patient would have overactive bladder. Okay, so this is detrusor overactivity, and I see this scale has from the rectal tube, pressure of the abdomen, and then pressure of the vesicle, and the computer will subtract it to give you the real pressure of the bladder, which is detrusor. So we're not going to talk about it, but it's very important to understand and to tell your patient if they are going to go for urodynamic. Now, after that, you are going to look at the treatment. So the first line treatment, which is always people would miss, is behavioral management, which means that you have to have fluid management. Now, patient, if they drink a lot of water, they drink a lot of coffee, soda, or alcohol, or they take diuretics, you have to modify it, because this is part of the treatment. And as I told you before, if someone is drinking a lot of coffee, I never tell the patient to stop anything. But if they drink a lot of coffee, they need to decrease the intake, but I will never tell them stop it. And sometimes patient who has moderate fluid intake, I would tell them that, you know, like you need to schedule your void. So for example, if the patient would leak or would have severe urgency after 3 hours from going to the bathroom, I would say after 2 hours and a half, you need to go to the bathroom. Do not wait until you have severe urgency, okay? So this is a time voiding. And try every time after that, you know, to hold your urine for another 5 minutes and increase it gradually, because holding the urine sometimes will suppress the overactive bladder and will give you a chance to have a bigger size of a bladder, urine volume. And of course, you know, like we have colleagues actually in the physiotherapy that they are specialized in the pelvic floor muscle, and they would have a lot of techniques. It's not only Kegel exercise that everybody knows about it. They have pelvic floor muscle training with or without a biofeedback, where they can properly teach the patient how to contract that muscle. And sometimes they use also more advanced technique that would stimulate the pelvic muscle, you know, to contract and to be stronger, because doing that would help to treat the symptoms of overactive bladder and decrease the chance of having urgency, frequency, and urgent continence. The second line of management is medical treatment, where we have two types. The first one, which is everybody knows about, which is antimuscarinic. Antimuscarinic is very simple. It goes to muscarinic receptors and block them. Bladder has a lot of M2, but M3, which is the one that causes the detrusor muscle contraction. So basically, antimuscarinic, we stop the contraction of the bladder with such a medication. And we're going to talk about the side effect of it. The other medication, which is now available in the market, it's the mirabegron, which is a lot of advantage actually. Now we have in overactive bladder management after we get beta-3 adrenergic agonist, because this would have a different side effect. None of them almost is similar to antimuscarinic side effect, and would help to relax the bladder as good as antimuscarinic or anticholinergic. Now, if I go back to history, and most of you actually who treated overactive bladder before, like you had experience with oxybutynin or Ditrobat. And then, with time and research and improvement in the basic science, we got the tolteridine and also Ditrobat extended release. And tolteridine, we have it in the market as Ditrocetol. And then in 2000, we had the extended release. Each time we move in that direction, we have a better medication with less side effect. However, there is no difference in efficacy. So they all do the same job, but the side effect is bad. And I will tell you in the next slide about the side effects. If you look at the distribution of muscarinic receptor, and I told you that in the bladder we have M2 and M3, but it's also found in the salivary gland, in the brain. You have M2 in the heart and in the brain. So that's why the side effect will be related to the distribution of the muscarinic receptors. What would you have is dry mouth because of the blockage at the salivary gland, constipation, blurred vision, tachycardia, and cognitive function impairment because it affects the brain. It's very important, and I always mention that the patient will love you if you tell them, about the side effect, because it's very bad that, if the patient develops a dry mouth without telling them, like you might have this. It's not necessarily every single patient would develop it, but it's very bad if the patient develops that without being informed. I don't tell them to drink water, but chewing a gums, if they can, would help. Constipation. Sometimes some of our patients, they are already constipated, and we know that constipation can worsen the overactive bladder symptom, especially in elderly. So if you give them a medication that causes a constipation, then you're gonna increase their symptoms. And if they did not have it before, they will need to know that, the constipation, if it develops related to this medication. Blurred vision is not very common, or tachycardia. Cognitive function, especially in elderly, is very important. Someone who have maybe some cognitive impairment, you should not add to that anticholinergic, even though we have the quaternary amine, because most of anticholinergic is tertiary amine. The quaternary amine, like trospium chloride, it does not cross the blood-brain barrier, and it might be good in elderly with cognitive function impairment. Now, there is plenty of data and enormous publications in urology with regard to overactive bladder and the medication. And out of this, the Cochrane review done that actually more than once. And the conclusion is that extended release is better than immediate release in terms of side effect, the dry mouth or constipation. Number two, in terms of efficacy, they're all the same. Okay, they don't have a better efficacy over each other. In terms of side effects, definitely that, like some medication like Visicare, the sulfenacine, it has at least side effect compared to the others in terms of dry mouth or even constipation. And that's why nowadays, most of the people, they write Visicare because it is better in terms of side effect. Now, can you change the anticholinergic if the people, develop the side effect or they did not improve, and it would achieve a good outcome? Yes. And there's many data, and this paper actually showing that using a sulfenacine or Visicare after Ditrocetol extended release would give significant improvement in urgency and other symptoms and improve the quality of life. And I always tell people that, you know, like if you failed, even if you failed Visicare, try other medication, Detroban, Detrosatol. So of course, this is before the era of Mirabegron, but you should try an alternative. But why people they changed? Because we didn't have at that time Visicare, so that's why people comparing this Detrosatol to Visicare, because Visicare have a better side effect symptoms compared to Detrosatol. Now, many patients ask, okay, doctor, when I'm gonna stop this medication? I personally tell them, take it for 3 to 6 months, and you can stop it for 1-2 weeks. And if your symptoms did not recur, it's fine. But very low number of patients will not need it within 6 months. And I tell them if symptoms recur, you go ahead and restart it again. It is not a harmful medication, usually the anticholinergic, and it was very helpful in controlling the symptoms. The only problem is the side effect. And in this study, which shows that, you know, like people don't know when to stop, but most of them, or most of the people treating the patient, they would say 3 to 6 months, like what I said. And this paper, it showed that, you know, many patients, they would require more than 3 months because the patient's symptoms would recur within 4 weeks. Now, the other questions that people always ask me is that, you know, giving anticholinergic, would it cause urine retention? The answer is no, unless the patient has a high residual before like this, more than 200 ml. Majority of the patient, even if they have benign prostatic hypertrophy, they would not go into retention. It's very low percentage, and it is safe to use this medication. And in case patient developed urine retention, you just stop the medication and things will go back. Now, the main problem of overactive bladder medication, especially the anticholinergic, people, they will never adhere to the medication because of the side effect most of the time, but there's other causes. And you see, comparing to other classes of medication, we are in overactive bladder medication the lowest compared to other anti-diabetic and other things. So looking at, you know, persistent with prescribed antimuscarinic in overactive bladder, elderly, usually they are better than young people to keep their medication. And Visicare or sulfaphenacin associated with higher level of persistent compared to other antimuscarinic because people have less side effect. And that's the main problem, that people, because of the side effect, they don't continue the medication. Now, we have the beta-3 agonist, which is Mirabegron. It's a very good medication. It works by stimulating adenyl cyclase, which increase intracellular CAMB, causing muscle relaxation. So basically, it works to relax the muscle in this area. Now, it has been in the market for many years. Unfortunately, the final approval and registration in Saudi Arabia was in 2019, as far as I know. And when we ask you the question about patient with hypertension cannot take Bitmega, it was false. I know 1/3 of you did answer yes, no. Only if your patient has severe uncontrolled hypertension, then it is contraindicated. But controlled hypertension, mild hypertension is fine. You can start it's safe to start the medication. Now, beta-3 agonist, which is like a Mirabegron, is a safe medication and another class we use for overactive bladder. We can avoid the side effect. As I told you, we always talk about side effect because this is what we have as a problem in treating patients with overactive bladder. The dry mouth and constipation does not happen with mirabegron. They can be used in patients who are not able to tolerate it or in whom the use of antimuscarinic may be contraindicated. Systemic reviews note that similar efficacy between the two class, anticholinergic or beta-3 agonist, and they have, as I said, a higher patient adherence to treatment at 12 months or 1 year when they use the mirabegron compared to anticholinergic. Now, the other question, which is very important for you now, okay, I have a patient that uses Vesicare. He is improving, but his symptoms is not completely disappeared or still is symptomatic. You can combine bitmega, because when we ask the question, never combine Vesicare with bitmega, also maybe 1/3 answered yes. No, it is not true. You can combine them. And this is the beauty of having bitmega in your armamentarium, because you can use both together to treat or improve the patient's symptoms, and it is safe. The side effect, if you ask, increase in the blood pressure and nasopharyngitis, uncommon, or UTI, uncommon, or urine retention is uncommon. In pooled analysis, the rate of cardiac adverse event using the 25 or 50 milligram of mirabegron, and in comparison to anticholinergic medication, severe uncontrolled hypertension is contraindicated, as we said before. Other than this, it's fine to use. Combining them is safe, and you can use it for patients who need better, acid control. And of course, you can use beta-3 mirabegron as a single agent or monotherapy. Now, this is usually will treat majority of your patient, looking at behavioral modification and, looking at the second line of therapy, which is the medical management. If they fail, now you need to send them to a specialized person, okay, where they have another treatment to offer this patient. I will go quickly through it. And the first one, which is intradermal onabotulinum toxin injection, or Botox, which is the same toxin that people use in the face and in other organs. And I would say that, it's very effective in overactive bladder. We give 100 units, and we give it all over the bladder, as you can see here. And we mix it with 10 ml, and then we give in every injection 0.5 or 1 ml, and we go randomly in the bladder, posterior wall, anterior, and 2 lateral walls. Now, this is very effective, and it has FDA approval, and there's many studies that shows that it's effective as compared to placebo, and there's a lot of patients would improve. At least 70% of your patients will. Now, other treatment option, which is sacral neuromodulation, and it's insertion of electrodes in the S3 foramen, where it's in contact to S3 nerve and connected to the battery outside. It's a very expensive treatment that costs almost $75,000. We give it to refractory patients to medication or even Botox, and you need to have an enthusiastic patient that would be able to cope with the pulse generator and change sometimes in the frequency a bit complicated. You need a good patient. And again, as I said, it's expensive, and you need to change the battery if it works almost every 3 to 5 years. But this is another option we give to the patient. And again, 50 to 60% of the patient might improve with this medication. And there's a lot of data showing that over the 5 years, there's a very good and maintained outcome. The last one, which is a percutaneous tibial nerve stimulation, which is a test we do it in the clinic. Basically, the patient would come multiple sessions for almost 12 weeks. He comes every week, or she comes every week. And we stimulate, again, with the pulse generator here, the posterior tibial nerves at the level of a medial malleolus. And patients stay for 30 minutes in every session. And it has, again, a very good outcome, which is 50 to 60%. It's less invasive compared to sacral neuromodulation, but it's need a lot of work and a lot of time from the doctors and then specialized nurse actually to stay with the patient and to teach, and the patient also to come every week for this treatment. My last slide, I would say that, we cannot cure, in summary, we cannot cure overactive bladder, but we know how to treat it. We do not know the exact cause, but we know also how we treat it. It's a very prevalent disease. It is very costly, as we said, costs billions and billions of dollars in the United States, and also in Saudi Arabia, it costs a lot. We have now mirabegron, which is work as good as anticholinergic in treating overactive bladder patient. It has minimal side effect, which is mainly cardiovascular. Combining them with antimuscarinic is safe, and it's improved patient symptoms. And instead of going higher with the dose, you can combine the medication and reduce the antimuscarinic side effect. In patients who are refractory to the previous or the medication treatment, we have other interventions that should be considered in a specialized center with a specialized doctor for dealing with such condition using Botox or sacral neuromodulation or posterior tibial nerve stimulation. Thank you for listening, and I would wait for Dr. Ghadir to give the questions.
Thank you very much, Prof. Waleed, for a very comprehensive talk. So we can go ahead and have a look at the questions. Actually, the first one is a comment. So we would like to welcome in our audience, we have some physiotherapists, so they are very welcomed, and we're happy to have them join us in this talk.
I'd like to thank them actually for coming.
Absolutely.
We depend a lot on them.
Yes, we do. Yeah, as you mentioned in your talk, they're a very integral part of our treatment for both OAB and other types of incontinence. So the question that we have here is, after use of 2 different anticholinergic, can I give Botox? And then can I justify this?
Of course, first of all, we have to go to define what does it mean refractory overactive bladder. Refractory overactive bladder, that you give your patient 2 types. This is there's some consensus, with this regard, that you give 2 medications, everyone at least 1 month, and they fail. And then, of course, you can give Botox, 100 unit, as I mentioned, for overactive bladder, non-neurogenic. However, make sure that this patient would have a urodynamic study. And of course, usually, unless you are a urologist or urogynecologist like Professor Ghadir, where you are specialized in this field, then you cannot give Botox because you need to do cystoscopy in order to give this patient intradetrusal Botox.
Okay, thank you. The next question that we have here is, if the patient is already known to have OAB, do you still or must do a urine analysis?
Well, non-OAB, it means that patient had a workup before with a negative urine analysis at the beginning. It's a must. So if someone comes to me, even me, for example, you know, like, or you, Professor Ghadir, in your clinic, after he or she failed previous treatment, I would repeat even urine analysis. Urine analysis
Absolutely.
is a very important test to make sure that this patient does not have a UTI or other conditions. I need to know about hematurias and other factors. So it's a must to do urine analysis.
I second to that because it's cheap, it's easy, and you get a lot of information from that simple test that can be done. The next question over here is about a lady with overactive bladder after vaginal delivery with history of urgency and incomplete bladder emptying only 3 days after delivery. So is this considered overactive bladder, in your opinion?
I would say, you know, like this is a very unique patients where it's very common, and I'm sure Dr. Ghadir would see more of those patients after delivery, and I don't consider them pathological at this stage. I would wait. 3 days is not enough for a lady after delivery, and most of them, it will disappear within a month or two.
Absolutely. And I think after delivery, number one, they need to rule out the UTI because we put a lot of in and out catheters during delivery. So this would be the number one thing to look for. And number two, high post-void residuals, because sometimes, especially if she had a prolonged second stage, the baby's head was pressing on the bladder, she might have distended bladder overflow incontinence more than overactive bladder. So her PVR should be looked at before we label her as anything. And the whole body takes about 6 weeks to go back to its normal, you know, pre-pregnancy status before we start to label her as an OAB or any other diagnosis in that term. So that's very good.
And I usually
Somebody here,
tell them to wait. You know, I just reassure.
absolutely.
And it doesn't happen frequently to me, but when I get asked, you know, like this is that. Yes, please, Dr.
Okay, the next one is a basic question about the normal post-void residual.
Yes, normal post-void residual is 0. However, we cannot say 0 gonna happen all the time, because usually to measure the post-void residual, you ask the patient to go to the bathroom and or to do ultrasound in general before, and then they go to the bathroom and then you recheck it. Most of the time we accept less than 50. We say it is normal, especially if the pre-void was 400. It's completely fine to have 50, because there is a time, and you know that urine or the bladder filling up with urine is continuous. So it's not, and most of the time, you know, people when they go to ultrasound, they ask them to drink a lot of water. And by the time they go out from the bathroom and they go to check their scan, it's a bit, 5 minutes goes there, which is, that's why we said we accept 50 or less. But if you're gonna say what is normal, it should be 0.
Okay. Well, for ladies, we usually say it has to be 50% less than 50% of the voided volume, which is the acceptable PVR. So it all depends on the bladder capacity, I guess. The next question here is about mirabegron. Can it be used for OAB due to chronic non-bacterial prostatitis or CPPS, which I have no clue what that is?
Maybe chronic bacterial prostatitis. It's not. This is a treatment for overactive bladder, which is not related to prostate treatment. That's simply the answer.
Okay. Somebody here is giving a comment. They would like to have some guidelines on when to stop the medication after they see improvement in LUTs. So when do you recommend cessation of medication? After a success story?
Well, as I said, there's nobody actually knows the exact answer. And I usually or personally would tell the patients to stop after 6 months to 1 year. And then I tell them if your symptoms recur, you just restart the medication. There is no clear guidelines, okay, when to stop the medication. But when you give it to your patient, don't tell him that, and that's why I stressed in that it's not a cure. You tell him, you know, like, I've seen some patients that they have, you know, like their symptoms transient and then after treatment disappear, but majority, they would need medication for a longer time. So the answer, I would say 6 months to 1 year. And if your symptoms recur, you can restart it. It is safe medication, as I said.
Okay, the next question is...
Let me ask you, Prof. Ghadir, so what do you do with your patients?
I usually minimum 6 months to a year if she doesn't develop any major side effects. And then after that, we try to slowly wean them off. Some people we succeed and some people just, you know, they come to accepting that they're going to need to be on this medication for life.
Yeah, yeah.
So basically you take it one case at a time. Some people we succeed in weaning, some of them no.
Absolutely, absolutely. And you should,
okay.
And that's what the message I tell usually, is that don't tell them just 3 months, 6 months, and you should be fine.
Absolutely.
You might need it for a longer time, but
absolutely.
Stop it. You lose nothing by stopping it.
Yeah, because it's all about expectations from the patient's side.
Absolutely.
Okay, there's another question about the discontinuation. We all know that people discontinue antimuscarinic because of side effects, mainly dry mouth. So why do they stop mirabegron?
Why do they stop? There is a lot of factors, you know, other than the side effects. Some people, you know, like they hate taking medications, you know. They might take it for sometimes. Majority of people actually, they don't like medication. Even doctors, they don't like to take medication in a regular base every day. The other thing is that, you know, even mild symptoms might make people stop it. The third, you know, like people sometimes they think it's not curable disease. Why would I take this medication? So there's a lot of factors, but what is important that people, they don't stop it because of the side effect as anticholinergic. This medication is very important to have it in our practice because it gives people a chance to change, you know, like the medication that causes a bad side effect. You know, you and I, Dr. Ghadir, see a lot maybe of those patients. That's why we know that a lot of them, they complain of side effects. And we know that, and that's why we are very happy to have such a medication like a mirabegron that would help. And also there's a lot of patients that you can avoid giving them, which is the question related to Botox. You can avoid giving them Botox because you have now the mirabegron that you can add it to anticholinergic to improve the patient's symptoms. And at one stage, a long time ago, and still maybe some people, they practice it, they give 2 anticholinergic for those who did not improve. But giving 2 anticholinergic,
it's more side effects.
It's terrible, you know? So I don't think I want to have a better control or in my urinary symptoms, and I have a very bad constipation or dry mouth.
Okay, I have a question for you. So if access was not an issue, would you use Betameg or mirabegron as first-line treatment for OAB since it has minimal side effects?
Yeah, that's a very nice question, Dr. Ghadir. Look, when the European actually society gave a guidelines at the beginning because they didn't know a lot about the medication. They said it can be used as a second line treatment to anticholinergic. And then now people, they change and they said, yes, you can start with it. And I personally mentioned that even a year ago. And I said, I mean, what's wrong with starting this medication as a first line? If I have less side effect, why I need to suffer? Why the patient need to have a side effect in order to improve? At the beginning, maybe people, they were afraid from the safety issue. And now they have enough 80 years of experience, and people now, they said, like what you mentioned, Professor Ghadir, that you can start this as a first medication.
Very good. Somebody is asking about OAB in teenagers. Does it have the same etiology as adults, or is it, different pathophysiology?
It should be the same. And in that age group, because, if they are like 12 or, 11, I will be worried about other voiding dysfunction factors, and I need to make sure from the history and even the physical exam, they don't have other pathology. But they don't have, if it's overactive bladder, which is, we call it idiopathic, without any cause, it's more or less the same pathophysiology.
Absolutely. Okay. I think we answered this question. Okay, somebody is asking about the dose of Botox that you're going to give to the patient. Will it be 100, 200, or 300?
It's for overactive bladder, which is non-urogenic, the FDA approved 100 unit. If we go to a lot of basic research we did before, I have a lot of experience in Botox actually, because I started actually working in Botox in 1999 when I was a resident and then as a fellow, and I had a lot of work in the labs. So we reached before that 150 is the best dose, but because of many factors, you cannot use 150 because the ampoule usually even comes as 100 unit. People, they said, let's try to see a different dose until FDA reached into 100 units. And in pediatric, even we used before in urogenic bladder up to 300. And at that time when I was a fellow, actually, we were trying to find the best dose, and we did a lot of study to reach into a calculation of, like we give a 5 unit per kg, which is sometimes go even more than 300, but the maximum we give is 300 units. Now, we have to stick to the FDA because it was done through many phases, and they reached that 100 unit for overactive bladder non-neurogenic. For neurogenic bladder, 200 units is the dose that people use. In my practice, sometimes, like I have patients already before, because before it was 300 until the FDA approved. I give sometimes 300, but final, I would say, answer for anybody who want to have the right FDA approved units is 100 unit and 200 units for neurogenic.
Okay.
Sorry, I give you a long answer, but it's because, the person who asked this question, probably he knows about 300 and 200 and what happened. That's why I tried to explain to him.
No, very good comprehensive answer, doctor. Okay, next question. What is the approach in women with mixed urinary incontinence?
Yeah, in my practice, the way I do it, first, I treat the easy one or the non-invasive one. Let's say, I don't think it's easy, it's non-invasive, which means I start, first, I have to make sure in the history which one is worse for the patient. Then I go with overactive bladder because I usually give them medication, and if the symptoms improved and nothing else, patient complaining from, or very mild stress, then I would do nothing. If the patient said, my symptoms improved, but I still have the stress incontinence, and whenever I cough or sneeze, then I'll go ahead and do, whatever. And of course, provided that we failed physical therapy and other things. Okay, so then I go and do minimal invasive surgery. If the patient, again, failed every things with anticholinergic, and they still say that I have a bad symptoms still, despite using anticholinergic for more than 1 month, then of course urodynamics should be done to confirm the diagnosis. And then I will tell this patient, first, I'll do the surgery for you because you still have the symptoms, but I don't guarantee that you're gonna be very happy after that, because even if stress incontinence disappears, the symptoms of overactive bladder might be worse than what you have now. So it's very complicated and when you have such a patient, but I always go with the simple one, which is treating the overactive bladder, and then after that, I treat the stress incontinence. Provided, again, I want to stress in that patient failed all conservative management, including behavioral modification, and of course, physiotherapy, then and then medication, and then after that, I do this. What about you, Professor Ghadir?
Well, plus minus the same, but I try to ease out from her what's bothering her the most, because a lot of ladies kind of have a symptom that's more bothersome. So I kind of approach and say, hypothetically speaking, if I can manage only one of your symptoms, either the stress or the urge, which one that you really want me to kind of, approach it first? And she'll usually guide me through which one is bothering her and really affecting her quality of life. And I would go based on that.
Great. Yeah.
Okay. We have 2 questions in one. So one is asking, would you do Botox before, would you do urodynamics before injecting Botox in the bladder? And the other question is, if you have no access to UDS, would you still go ahead with Botox?
Okay, very good question. First, I don't encourage anybody actually to do Botox without a urodynamic, because from experience that you might deal with the wrong diagnosis without urodynamic. You might treat patients with, for example, poor detrusor contraction and make him worse than before, because when you give a Botox in the bladder, you're gonna, I would say, paralyze the bladder or the muscle for a period of 1 to 2 months, because it's regained back the activity, number one. And that's why I have to tell you, in my experience, whenever I see a lot of refractory, because, I work as a tertiary hospital, I see a lot of patients who failed everything. And when you tell them, especially in our society, that the patient with overactive bladder, there's about 10 to 15% chance you're gonna go into retention. I didn't have, like exact number yet, but I would say 50% of them, they would refuse the treatment. And they think it's better to stay with overactive bladder symptoms rather than going into intermittent cath, because when they go to retention, this is the only treatment. And in 10 to 15%, they might go into retention. Not only this, that sometimes you have a diabetic patient with a poor muscle contraction, that if you inject them with Botox, they go into retention. And they might not urinate again because the bladder itself was bad from the beginning. And then, you are not justifiable for doing such a treatment without doing a Botox at that time, without doing, urodynamic. So urodynamic, in my opinion, is very important before such invasive treatment, but not before oral medication when you see the patient first time.
Okay. Can OA be present at night only or more severe than the morning? And how could you approach and treat these patients with, a nighttime problem of OAB more than daytime?
Yeah, they are the worst, actually, those who comes with the nocturia, those who wake up from sleep to go to the bathroom, especially those who are not able to go back to sleep when they interrupted their sleep going to the bathroom. So those people, they have a very bad quality of life, very difficult to treat. And most of the time, overactive bladder patients, they have daytime problem. those who wake up at night, you have to make sure there's, like a lot of things I need to work in it, especially, like sleep apnea. You need to make sure they don't have, like a cardiac medication or the diuretics that they take late in the day. You need to make sure that they have no other medical disease. So they are very difficult. When you treat them, anticholinergic will not work for those patients at night. Usually very difficult. I need to make sure they don't have a BPH. Sometimes they have nocturia. So it's not the same treatment, but majority of overactive bladder patients, they have a daytime problem.
Okay, thank you. The next question that we have here, is there any role for laser in treatment of OAB with urinary incontinence?
If they are talking about physiotherapy, they mean, or laser for with the physiotherapy, or in urology, or in, because we don't have laser treatment in urology for overactive bladder. But I know that in physiotherapy, they have a lot of minimal invasive treatment and advancement in the treatment right now, including sort of a laser therapy that they use. So that's why I don't know if he meant or she meant that.
I'm not sure. It's just a written question, but I'm assuming it's vaginal laser treatment, and the answer would be no. There is no role for vaginal laser in the treatment of OAB, nor stress incontinence. There's no solid evidence that it would have.
Yeah.
Okay, there's a question about patients with MS, multiple sclerosis. So with problems with voiding dysfunction in OAB, how do you recommend approaching those? Or is there a role for Botox for MS patients?
Yeah, those are different group than the one we are discussing now. Okay, yes. So those are the neurogenic bladder patients, which is spinal cord injury, patient with multiple sclerosis and CVAs and name it. They are different, but they might have the same treatment. Okay, so with multiple sclerosis, you can use anticholinergic, you can use mirabegron, you can use Botox, and the Botox dose is 200 units. However, those patients, most of the time, they don't void well. So they need to have intermittent catheterization before even giving them Botox. You have to make sure, and they understand. The problem sometimes they are stubborn. They don't want to do CIC or intermittent cath. So they refuse that the Botox. But in order to give somebody 200 units, you have to make sure that he does intermittent cath because he cannot urinate. And patient with MS, they have overactivity, the bladder contract, at the same time their sphincter contract, they have interrupted stream. It's very bad voiding pattern, and you can give, but again, it's a different entity, but you give it when they are doing intermittent cath and when they failed anticholinergic.
Okay, there's a question here. Why you have mentioned that you'd ask your patient to reduce caffeine. You don't ask your patient to reduce caffeine intake, but you do. I think it was just a misinterpretation. You said you don't to stop. But
I don't let them stop. I don't tell them stop because people don't like to stop whatever they like. So if, for example, if you drink a coffee every day and you drink 2 to 3 cups, until you drink 1 only. But if you tell him not to drink, maybe he will not, comply with your recommendation. So that's what I said. I didn't say, I let them go ahead. I say I don't stop them, but I decrease it.
Yeah, I just wanted to clarify that point.
Yeah, sure.
Yeah. There's another question about combining Vesicare, BetMeg with Omnic. Can they do that?
Vesicare and Omnic and BetMega.
Yes.
I don't see why not. Everyone work with the different, I would say, mechanism of action. Omnic is alpha blocker. the mirabegron beta-3 agonist, and Visicare is anticholinergic. However, you have to make sure, of course, in the patient with BPH, difficulty voiding, I just want to make sure that they empty well, because now you are putting more medication to relax the bladder. So as I said, it is safe to start anticholinergic with BPH because less than 1% of the patient, they will have retention. But when you add mirabegron to it, you might increase the chance of urine retention. Unless the patient voiding well, I don't see why not to use both of them with the Omnic if they can empty well.
Okay. The next question is, if you want to combine BET-MEGA with Vesicare, what dose of Vesicare would you be giving your patient, 5 or 10?
If you started this patient in 5 and he did not improve and increase it to 10, you can combine the BET-MEGA. If you just started it with 5 and you did not increase it to 10, you can use 5 with BET-MEGA. So it's fine. So it depends where did you reach. If the patient improved in 5 milligram, but still symptomatic, and now you have BET-MEGA, I add BET-MEGA because the side effect is there. Even though some, they might recommend to go to 10 before they go to BET-MEGA, because maybe the cost or other factor. But I believe before you go into, unless the patient tolerating it, no side effect, I go to 10 milligram. So you don't need BET-MEGA at this level if the patient is tolerating it without any side effect. So go from 5 to 10. But if you already reach 10, still symptomatic, or the side effect of is high with 10, you go back to 5 and add BET-MEGA.
Okay, I think we'll ask the last question, then we'll conclude. There are multiple questions, but I'll summarize them in one. It's about OAB in children. So could you use BET-MEGA? And if not, what is the best treatment option for OAB in children?
Sure. First, I don't know about the safety in children using BET-MEGA. I know that some people, they used it, but I cannot recommend it because I don't have the data. Before, we only used the oxybutynin or ditroban for pediatrics. Some people I know, they use sometimes the ditrocetol. Recently, we have now FDA approval, which is a very good news, of Visicare syrup, which can be used in pediatric. I think this is a very good medication for pediatrics because it's syrup, easy to use. We always have a problem. The family comes to me to find ditroban or in outside pharmacy on some hospitals. So that's, I think, the answer. And I think it's a good news for pediatric urology or people in pediatrics dealing with overactive bladder.
Okay, thank you very much, Prof. Waleed, for an amazing, comprehensive talk about overactive bladder. And I would also like to take this moment to thank Saja Pharmaceutical for Men's Health for arranging this educational activity.
I'd like to thank you also, Professor Ghadir. You've been amazing, actually, moderator, and I'm very happy, actually, to be with you and with the group. And thank you to Men's Health and also to Saja.
Thank you. Bye-bye. Good night.
Thank you.